Thank you very much. And our third speaker for this session, before we go into a discussion, is Laura Williams-Goff, who's a medical oncologist and well known to many in the foundation. She specializes in gastrointestinal cancers. She had a medical degree from the University of Texas Health Science Center in San Antonio, went on to complete a residency in internal medicine at the University of Texas Southwestern Medical Center in Dallas. And she then moved on to Vanderbilt University for fellowship training in hematology and oncology, where she then joined the faculty in GI program in 2007, completed a Master of Science in Clinical Investigation in 2008. Additionally, she has served as the Associate Director of the Hematology Oncology Fellowship Program at Vanderbilt since 2009, and is interested in developing the use of new therapeutics in GI malignancies through clinical trials, translational research examining predictors and response to targeted treatments. Laura, the podium's yours.
So in my role as a fellowship program director, I love connecting people together and to help make the best connections for collaboration. And so I think perhaps that's why I was asked to give this talk, because I have, by hook or by crook, participated in lots of different mechanisms to answer questions in this disease. So if I can get the thing to work. There we go, the big green arrow. These are my disclosures, and so my objectives for this talk are twofold. In the best possible way, the Cholangiocarcinoma Foundation, since I started working with them several years ago, have charged us to work together and to think outside the box in how we conduct ourselves. And I wanted to give a broad overview of how we are doing that in the United States. I think Lipika outlined that there is lots of momentum, and we are working together. And then for investigators, each year I meet new investigators that come to this meeting, and even today I've met some, and ways that they can get involved. So Lewis has been highlighted as kind of the original big collaboration supported by the Cholangiocarcinoma Foundation. This GWAS study, I won't go over any of the detail, but it has sites all around the world, as you just saw, with lots of collected samples and sort of the original collaboration supported by the Cholangiocarcinoma Foundation. In 2014, I put Ghassan's picture up here because he engineered a connection between myself in the middle of the country, Maeve Lowery on the East Coast, and Katie Kelly on the West Coast. And we were able to secure funding from the Cholangiocarcinoma Foundation to look at outcomes in patients treated with second-line therapy in biliary cancers in this country. This contemporary series of nearly 200 patients led us to the conclusion that these patients are living long enough to ask questions of clinical trials, but the therapies that we have are really inadequate. The duration of treatment is basically the duration of time to your first CAT scan. And this will, while seemingly a small conclusion, I think represents a foundational finding that will be important in our upcoming trials that we have planned. Following this, Lipika led a large database effort looking at cholangiocarcinoma in the young. She was able to include several centers across the country, and found that the patients with age of initial diagnosis under the age of 50 really did look different from the patients, older patients, that more likely to have PSC, more likely to have bone metastasis, and interestingly, as you've heard a lot about molecular mutations mattering, more likely to have an FGFR2 fusion. And variables which might have been thought to be significant were not. Another mechanism that we have been fortunate to participate in, led by Dr. V. Sahai out of the University of Michigan, utilizes the precog mechanism through which is the early phase partner to the U.S. cooperative group studies. He looked at the combination of nab-paclitaxel and gemcitabine, something you've heard quite a bit about at this meeting, in advanced or metastatic biliary tract cancers. The interesting piece of this study, I'm not going to review the data, which is provocative, but that it accrued 74 patients in 18 months, and this completed in around 2016. I think this was the first hint that we were able to do these studies in a reasonable period of time in the United States and work together outside of industry-supported traditional drug-sponsored trials. It did accrue 23 sites across the US and Europe through this mechanism, with, as I said, provocative efficacy. So Dr. Sahai, I think, is a hidden gem that's developed his own sort of independent network with biliary clinical trial sites and has several additional planned trials, both first line and an interesting maintenance trial that's ongoing. Obviously, the gemcitabine and nab-paclitaxel was looked at in combination with cisplatin. Dr. Schroff's data has been presented earlier today, among other times. But this multi-center open-label single-arm phase 2 trial of the drugs given sequentially led to outstanding responses, including 2 pathologic complete responses. The reason I highlight this is now, as you've heard, the first approved phase 3 randomized control trial in biliary cancer to be conducted through the cooperative groups. The study design looks at first-line advanced cholangiocarcinoma and gallbladder cancer, giving gemcitabine, cisplatin, and nab-paclitaxel compared to gemcitabine and cisplatin alone. And Mitesh, myself, and Dr. Jason Starr serve as champions. It was activated in record time. So I think another mechanism that exists within the United States is the ETCTN. This is the NCI's mechanism for supporting phase 1 and phase 2 clinical trials. Dr. Azad and Dr. Yarchwan's study, the cobimetinib and atezolizumab study. You've heard review of the data, but and again, it was a randomized trial of atezolizumab and cobi with atezolizumab. But again, the things I wanted to highlight were that one, this funding mechanism, I think this is the first time this has been used in cholangiocarcinoma, and I think Nilo's experience will make sure that it's not the last. You do have to look for additional funding mechanisms to support the study correlates, the accrual of 80 patients between February and October of 2018, I think, stunned the NCI and really lends credence to the fact that we can do these clinical trials in the United States when we work together, and these are even at very limited sites. So I wanted to speak to, you've heard again about this effort called BATCH. What is BATCH? BATCH is a coordinated effort across the cooperative groups in the United States, as well as with robust advocacy support from the Cholangiocarcinoma Foundation, supported by the International Cholangiocarcinoma Research Network. Essentially, we're trying to work with strength in numbers, building upon the fact that we have no second-line standard in biliary tract cancers. I hope that will change. We'll have to factor that into our decision or our plans for the study, but for now, there is no standard. But as we said, patients are hungry for second-line trials and live long enough to participate in studies. So we've talked a lot about how mutations matter, and there are lots of high frequency of actionable mutations in biliary tract cancers. But how can we incorporate this into practice? There was a big study called the NCI Match. There is an ongoing big study called the NCI Match, which tries to pair patients with a particular molecular alteration to a drug. But cholangiocarcinoma can be underrepresented on any individual arm. Although there are high efficacy for biliary cancers within MATCH, it doesn't give us a true disease context in which to ask questions about what is the real efficacy of these agents, and how can we lead to more rapid understanding of the role that these drugs will play in this disease. So the hypothesis behind BATCH is that their molecular alterations in biliary cancers can be used to predict benefit for subtype-specific therapies. And what we plan for this to be is a multiple parallel single-arm trials, and elegantly illustrated by Lipika in her talk. So again, this is looking at the second-line setting, and at progression, patients would be randomized to molecularly selected arms. One of the important pieces is that this credit is shared across cooperative groups. Basically, the goal of this is to be inclusive rather than exclusive, that this structure will be a platform for asking questions quickly and broadly for patients with biliary cancers. And specifically, there's a need for a no actionable mutation arm, and that patients are, we talk about high rates of actionable alterations, but that still leaves at least 60%, oftentimes many more patients sort of out of the running for these agents. And we know from our experience that unselected trials can accrue quickly. The statistical considerations for BATCH would be that each arm is evaluated separately for efficacy, and really to ask this question will take about 25 patients per arm, meaning I think that we can ask lots of questions with the opportunity for rolling trial design. What we know is that if you can accrue 80 patients in 6 months, we can ask a lot of questions if we have one master protocol. So some highlights from this concept include coordinated engagement of disease-specific experts. It's really humbling to see how many people have been hustling on behalf of this concept, and I think that it really is going to take that. The amount of people that were working just 2 weeks ago at GI ASCO and discussing this concept sometimes can mean that they're crossed communication, but I think in general it is working very, very well. There will be an opportunity, I think, with this coordinated effort to incorporate compounds with or without pre-existing NCI CRADA, and again, the opportunity to create a master protocol for this rare cancer. We intend to incorporate PRO quality of life endpoints, an effort led by Sheetal Kirchner out of Northwestern, and hoping that this will be a nimble platform so that patient care can keep pace with the new science. So again, this is even not the entire team of people that have been working, but as you can see, that it's a large group of really outstanding investigators that I'm fortunate to be a part of. And I want to highlight just the ICRN, which I think is going to be discussed later, and this slide is outdated, and even if I got a new slide this morning, it would have been outdated because there are people joining every day, and especially at this meeting. But I wanted to highlight that in the US, I think we have been historically behind the rest of the world in collaboration, but that we're getting there, and that we really want to work broadly with the rest of the world and learn from how you guys collaborate. So I'll put my program director hat on. I put Tony's face up here because he was the first person who treated me like a collaborator many years ago on a biliary cancer trial through another now defunct NCI mechanism. But that to be creative and I think especially for investigators who maybe aren't at the first tier institutions or who have maybe not the most robust level of research infrastructure or unlimited funds at their own institution, that there are lots of different ways to get research done, and there are lots of people who are happy to connect in this community. I feel very privileged to be part of this group of investigators who are really, really supportive and walk the walk of collaboration. I think it's really important to think about what you bring to the table and maybe what you can't do. I think we were, when connected with people around in a diverse geographic area, do we bring, we are the home of REDCap, and we brought that to the table. But there are things that I know where we are located in Nashville that we won't be able to do. I think as a good collaborator, you're a patient. I think it is amazing that there's a lot of interest, and now I'm getting daily solicitations to participate in industry trials, but I think it is important to make sure you choose your trials well and to commit and accrue to the trials that you are committed to. And I use Rachna's trial as an example. I plan to save spot for that because I think it will be potentially practice changing. Be generous, be persistent, and be curious. And in the spirit of collaboration, lots of people shared their slides with me, and I know that this was not even a comprehensive review, but thank you.